a little bit. It drizzled a little bit, but it's doing okay. I think this is my favorite part of the year in Bangalore. November, December. So how often do you guys meet?
The webinars are regular. It depends from each of the state chapters keep organizing it. So yesterday also, this morning also, we had a program. So it depends on the state chapter and what we do.
I see.
But we do an annual conference that is from the society. But
So
such
just the Karnataka
smaller
chapter or
events,
countrywide?
no, that's a countrywide. That's an international conference. But the chapter wise, they keep doing regularly. Every chapter does on their own. Some does every 1 or 2 a month or something like that.
You guys meet in person, or is it too corny to ask if you guys meet remotely?
No, both. It's both. So the annual
Telemedicine
conference
Society cannot be meeting in person, no?
yeah, not regularly.
I'm just
but
joking.
the annual conference, we all try to meet.
Right.
But me and Uma Shankar are meeting frequently.
I see. I see. Nowadays, to meet somebody in Bangalore also, it's a task in of itself. Unless you happen to work in the same area, to get to one end from just to go to the hospital 6 kilometers away, it's like half an hour, 45 minutes sometimes, depending on what time of the day you go in.
Yeah.
Mysore that way is very nice. It's very you sit in a rickshaw, you get anywhere in 10 minutes.
That's the beauty of the tier 2 cities.
Right. And it's so pretty. I like it. I never thought I would prefer any other city over Bangalore in India, but I have to say, I think Mysore is slowly creeping up there.
Yeah. So should we start? I think we should be able to start now and let the people join in. So that's fine.
Okay.
So,
carry on.
Yeah. Good evening, all. Welcome to this webinar on telemedicine practice in obstetrics and gynecology. And I'm honored to introduce Dr. Divyansh Soumya, whom we met, and we have been continuously talking on this particular topic for a long time now. Okay. I couldn't think anybody better than her for this particular topic because she has got a quite number of years of experience in this field. She's a board certified obstetrician gynecologist with over 20 years of clinical experience. And as a chief physician of family planning at the large public health department of the city of Houston, Texas. And she holds a master's in public health degree from the prestigious institution of Johns Hopkins Bloomberg School of Public Health. She's also certified in excellence in minimal invasive gynecology. She's mentored several residents on this various topic, and she has a lot of passion for women's health, who's focusing on improving maternal and child health, where unmet need, contraceptive needs, STI prevention, cervical cancer screening, and all. She's worked a lot even in telemedicine guidelines and all. So there's a huge list. I think it will take at least an hour to introduce her. So let me cut short. So we have one of the best person to speak on telemedicine and gynecology, and she has actually practiced it. So we would like Dr. Divyanshi to share her experience on telemedicine and obstetrics and gynecology practice. Over to you, Dr. Divyanshi.
Thank you, Dr. Uma Shankar. I think the best part of that introduction was the passion part, which is what rings true to my heart. So good evening, everybody. Thank you for taking time out to come and talk about telemedicine. We'll talk about telemedicine in general a little bit. And then we'll get into obstetrics and gynecology and the nitty-gritty of how to set things up and what are the things you should think about. Like you said, I used to work in the US, but this past year I have now moved to India and I'm now working in Public Health Research Institute of India in Mysore. But most of my telemedicine experience does come from the US, where I practiced for 20 years. I was trained there. I practiced there for 20 years. And like, many other high resource settings, we were fortunate enough to start telemedicine early, but hopefully as you leapfrog into it, you can learn from some of our mistakes and be smarter and savvier at it. So I'll move forward. I'm just going to start with a small quote by Albert Einstein. This is what I consider my compass that guides me and helps me sort of think this through. He said, 100 times every day, I remind myself that my inner and outer life depends on the labors of other men, living and dead, and that I must exert myself in order to give in the same measure as I have received, and I am still receiving. So we have all gotten where we have, through contributions from various members of society, from the government, from our communities. And so that is the reason, we go around and participate in these lectures and try to give back to our communities. This is my true north principle that I sort of live by. So moving on, let's see how I can. Oops. I am stuck. What happened? Okay, here we go. So let's start with the definitions of telemedicine. There are many ways to look at telemedicine. It's also called telehealth or digital medicine. The GMC of UK defines it as provision of medical services and patient care at a distance using communication and information technology. It broadly encompasses many, many different types of services in healthcare: virtual visits, behavioral economics, artificial intelligence, what we call M-Health. That is all part of telemedicine. Now, it has several divisions in telemedicine. It can be broadly divided into synchronous and asynchronous. Synchronous is when both the patient and the provider are in real time with each other, meaning you have a video visit, patient is talking to your provider is consulting with another provider. So that is what we call synchronous telemedicine. Asynchronous is where both parties are not on the screen or the monitor or the whatever mode of communication at the same time. So for example, if a patient emails a physician and the physician responds back at a later time, that's called asynchronous telemedicine. And then, of course, another way to divide it is another division is remote patient monitoring, like things that we use, that continuous glucose monitor we all put in our arms. So that is remote patient monitoring. In OB-GYN, we monitor the baby sometimes remotely. And then another division is M-Health. M-Health is all those applications we use on our smartphone, like, whether it is a menstrual period tracker or whether it is a weight loss tracker or whatever that might be. So telemedicine has been growing in, leaps and bounds. There have been over, 2,000 apps in OB alone in 2014. And these technologies increased even further when we went through the COVID pandemic, right? I mean, everybody started doing everything on WhatsApp and the phone and so on and so forth. Telemedicine can be used for diagnosis, management, education. First definition of telemedicine happened is when somebody faxed a fetal monitoring strip across a fax machine. But now the applications are much broader, so that has also grown quite a bit. And of course, with that growth comes the need to have evidence-based regulations. So the whole scope of telemedicine, where it was before, how do we provide telemedicine? How do we take care of our patients? Now, telemedicine there's a whole industry set behind telemedicine. There is policy around telemedicine. There is a need for monitoring and evaluation in telemedicine. So the scope of telemedicine has increased quite a bit as well. So let's look at telemedicine, in our neighboring countries and some of the bigger players during COVID, just to kind of get an understanding of where the world is today and what everybody is doing. So if you look at India, China, Singapore, Thailand, Australia, UK, and the USA, everybody's using telemedicine. If you look at this particular table here, everybody's using telemedicine. But then does everybody have regulations over telemedicine that govern telemedicine? Not necessarily. everybody uses telemedicine in sort of a different way. Some people have tele-ICUs, some people have tele-mental health, most people do teleconsults. And then this column looks at, policies and procedures, how many government organizations in which countries are actively involved with regulating telemedicine. And then every country except Singapore, has kind of signed on to that. And this is, as of right post-COVID. So let's look at telemedicine in India. Now, as of 2019, 66% of India lived in rural areas. And there's a lack of providers everywhere, in all areas, but especially specialists, right? So we can open a PHC in these rural areas, but we cannot take a specialist. We cannot take, for instance, a maternal fetal medicine high-risk OB specialist into every rural area. So I kind of want you to understand this backdrop as we explore, growth of telemedicine in India. So the first time telemedicine showed up in India was in 2000, when the government of India first adapted telemedicine, and the first few states to launch it, some of these players are not surprising: Kerala, Maharashtra, Tamil Nadu. Punjab is kind of surprising. I'm kind of surprised Punjab is on this list. And in 2001, ISRO connected Apollo hospitals in Chennai and Chittor to develop telemedicine. They took their whole infrastructure, and then slowly they added on more and more hospitals. And then 450 hospitals were part of this network by ISRO. And then the government of India, in the meanwhile, also initiated several new telemedicine projects. The OncoNet, the National Rural Telemedicine Network, the Integrated Disease Surveillance Project, and then private hospitals added on: Apollo, Asia Heart Foundation, and all these other players you see on here. And then finally, in March of 2020, I think COVID was like a big turning point in telemedicine in many countries, including the US, including the India, and the Ministry of Health and Family Welfare finally issued official guidelines that allowed a registered medical practitioner to practice telemedicine. So, what are the advantages of telemedicine? Why take this on? Why is this so important? Why our practices are already working without telemedicine. Now, what is the need to have this? Like, where is the scope? Where is the growth? Where is the benefit? So let's look at that. So number one, it advances equity and it improves access. In public health, equity, access, these are huge buzzwords. So it allows practitioners to have longer clinical hours. You can do this from home. You can do this from the hospital. It mitigates distance. You can now reach remote rural areas. So we were talking about lack of specialists in rural areas in India. Now through telemedicine, I'm sure you all know this, you can have specialists, connect to your patient in some distant remote village through a video portal. So that's one advantage in terms of equity and access. It also decreases a lot of patient resources. So it's less time away from home, from work, from family. There's less travel time and cost. There's less footprint on the environment. And there's also decreased wait time. I don't think we understand, how aggravating wait time is for patients until we have to wait to see another physician, right? And so this, I'll give you an example. My aunt had a multi-drug resistant infection, a knee infection. So, the first visit was through Jupiter Hospital in Pune while she was in Mumbai. We were able to set up our appointment on WhatsApp. We were, sent a link. We paid through a QR code, and we were all set to go in about 5 to 7 minutes. And, we didn't have to leave our hospital room. We talked to a very distinguished infectious disease specialist. And in 20 minutes, we finished the visits. He took a picture of the patient note and he sent it to us. Then, she went through her IV antibiotics. She ended up getting septic over a long period of time. And we ended up getting admitted to the hospital, to the ICU for several days. And then we ended up going for a follow-up visit. An hour and a half travel time in Bombay from home to the hospital, and an hour and a half back. Then we are navigating a wheelchair, so we are moving her from the home in our house. We're putting her in the elevator, in the wheelchair, bringing her down, transferring her to the car, back to the hospital. You get the idea. Wait time and wasted time are concepts sometimes that we don't rate very well. And it decreases cost not just for the patient, but for the clinic and for the hospital as well. You don't need to have as many staff members. When you are doing telemedicine, you can cut down on your overhead quite a bit. You don't need as many Q-tips. You don't need as many speculums. And one thing I haven't mentioned here is, workplace violence. So workplace violence, I don't think gets talked about enough. But workplace violence is going up not just here, but in all kinds of places. Also in US as well. So my son just started his residency in urology. And poor guy, second week of residency, he called me. He's like, Mom, my attending got shot and he died. And this was like not a urology attending, but an ortho attending next door. Excuse me. So basically, some patient was waiting for him for about 3 hours. He was stuck in the operating room. Patient got tired of waiting. Patient probably had some mental health issues. He comes in to see this doctor, brings his gun and shoots the doctor in the chest. I mean, when I first came to India, I heard about a practitioner in Kerala getting stabbed 92 times by another mentally ill patient. So if you're on telemedicine, you don't have to worry about any of that stuff. I think it decreases frustration both for the patient and for the provider. So what are the barriers in telemedicine? Why is it so difficult to adopt? I think broadly they can be divided into infrastructural, organizational, socio-cultural, and regulatory and financial barriers. So let's look at infrastructural barriers first. Now, infrastructural barriers themselves can be divided into those related to technology and those related to human resources. So I'll give you an example. Let's start about technology. In ISRO set up their telemedicine network for Madhya Pradesh initially in the early 2000s. And it worked really well in the beginning. But over time, ISRO went through its own updates, and the hardware they had set up in Madhya Pradesh could not keep up with the updates, the software updates that ISRO was rolling out. So eventually, all those computers just sat there, and it pretty much soon became obsolete. So that is a barrier, is if your hardware and your software cannot keep up with the need of current day as technology progresses, and also high-speed internet. I had to make sure my internet was up and running smoothly before I started this presentation. And, many patients especially don't have the resources to have reliable internet. Then there are HR infrastructural barriers. Did we train people enough? Do we have enough support staff? You need support not just when you set up telemedicine in the beginning, but you also need continued support as you're going through various phases and expanding your telemedicine. So that's something to consider. How do we mitigate these barriers? Well, you have to have a well thought out budgeting process. Before you sign up for telemedicine, you need to understand that this is not a one-time investment. There is a continuous investment going on, and you have to be able to handle and budget accordingly. It is better to start with a small area and expand. So when we started telemedicine, we only started it in one clinic. So we have a multi-specialty clinic. We have 30 different locations. We started it in one specialty, one clinic, and we left it at that for 3 months. And there were a lot of mistakes. There were a lot of learning opportunities. So the point is, you can start with a pilot. Everybody doesn't need to suffer. And then you kind of optimize your mistakes and you expand slowly, one step at a time. Peer-to-peer training. It's good to have champions in every department. People like being trained by people who they think understand them. They don't want some outsider who doesn't understand your specialty coming and training. So set up peer-to-peer training. And don't reinvent the wheel. So when I set up my OB templates, and I had my templates for different kinds of notes, like for a well-woman exam, I had one kind of note. For PCOS, I had a different kind of note. Now, every provider does not need to sit and start from scratch. You can have a shared repository where you can share those resources, and then every provider can take from that shared repository, tweak it to their liking, and continue using it. So have a shared knowledge base. It is much more efficient. Moving on to the organizational barriers. So if you don't have good support from your leadership, if the leadership doesn't understand your day-to-day challenges and doesn't understand that there is a learning curve to telemedicine, that you are not going to be able to hit the ground running from day one, you do need to slow down for a month or two, sometimes 3 months. You need to make investments, significant investments ahead of time before you bring this on. If there is lack of advocacy, and you need a liaison both for clinicians and patients. So clinicians don't talk IT, IT doesn't talk clinical medicine. And the same goes for patients. So you need somebody who understands the clinician's perspective as well as a technical perspective and kind of translates between these two entities. If there's lack of coordination among stakeholders, if IT and clinicians and leadership, they're not sitting on the same table and making shared decisions and, you know, being on the same page, that can be a problem. And there needs to be an action plan that everybody signs off on. If one person wants one thing, another person wants another thing, then this doesn't work. Now, when I'm talking about organizational barriers, I'm talking about larger organizations, such as like the organization that I was in, or many of you may be, and when you're part of a hospital. What do individual providers do? So that is a challenge we kind of went through with the City of Houston Health Department. So our budget was not big enough to take on a good EMR. And we noticed there were a lot of other clinics in low-income areas in our neighborhoods that had the same problem. So what we did is we formed a co-op. You know, several of us came together, we bargained and we had transactions with the EMR provider as a group. We were able to, you know, negotiate a support structure that helped all of us. And we were all sort of doing OB, GYN, reproductive health. So we had like a common face that we needed on our EMR. But many times, if you're individual providers or smaller groups and you cannot afford EMR or do not have as much organizational pull with your EMR provider, you can do that as a co-op. So this is an idea I kind of want to throw out there. So overcoming organizational barriers, well, you should have an administrative champion, somebody on the administrative side who is, you know, dedicated to putting all the different pieces of the puzzle in place to make this work. You need to have a clinical champion on the table of stakeholders. You need to have a day-to-day operations managers, not just somebody on an administrative level, but somebody who runs the day-to-day operations. And then the remote patient side coordinator is a person dedicated for patient satisfaction, because none of this works if the patient is not happy with what you're doing. So let's move on to socio-cultural barriers. So there are preconceived biases both for patients and providers. I remember when we started telemedicine back in 2006, we were all like, what is this? You know, this doesn't work. You have to touch your patient. How can you not make eye contact with your patient? How are you supposed to examine your patient? How do you know what their bowel sounds are doing? I was typing like this and looking at the patient like this. So my neck, I had a lot of problems, ended up in the chiropractor. I hated it in the first 6 months. We were all grumbling. And the patients were also, they had never done something like this before. But then, you know, slowly we were given time to create our algorithms, to create templates. And then I really started enjoying it after the first 6 months of the learning curve. You have to understand it takes some time. There are biases and you have to account for that. Once people get the hang of it, then, you know, it really becomes fun. There's clinician burnout as well. So, you know, all of a sudden now you're seeing 20, 30 patients, and then what is this new thing you have to learn and carry on? And, you know, this is not a whole lot of fun. But when it works well, and especially, you know, during COVID, if you have a good system, eventually it will work in the opposite direction and help with clinician burnout. I mean, you know, we were all in COVID wearing 2 masks and a face shield and no water to drink for several hours. Then finally we got a telemedicine visit. We got to take everything off. We sat in our office. We were drinking water. We could see somebody's face. It was, you know, it helped a lot. Another barrier is lack of confidence in self-exam. Self-exam meaning I'm telling the patient to, you know, where does it hurt? Can the patient examine himself or herself as well? Is the patient going to be able to give us accurate information? So that gets better with time. You know, especially in COVID, we were forced to learn and rely on this. So we would ask patient, you know, press here on your stomach. You know, does it hurt when you press or when you let go? Is there rebound or guarding? Are you able to press? So that comes with time, and you will learn the tricks of the trade as that happens. And then lack of digital literacy, both for patients as well as providers. I mean, how many providers have you seen that type with, one finger like this? It's hard. And there are things we can do. We'll go over them. In that particular scenario, you can use a dictaphone to kind of navigate that. So mitigating these barriers, make sure there is a care navigator. So one of the things that worked really well in our practice is anytime a patient could not log on or forgot their password or had any issues, they had a special one number that they were given that they could call. And we told them, test your connection 15 minutes ahead of time. And if you're having any problems, call this number. And all that person did was talk to patients and help them through their first time, their second time, especially if you have older patients that are not very tech savvy. You need to have, if you want this to work, you need to have some people who are dedicated to helping your patients. And then you tell the patients, I know this was difficult, but you didn't have to sit in traffic, you didn't have to pay for parking, so all that is good. Similarly, even providers need technology navigators. The first time we took on telemedicine, we used to call them red shirts. There were these people in red shirts who never saw patients, but all they did is anytime you had a question, you're like, okay, how do I do this? How do I order this medicine? Can I create a set of orders that I always use? There was always a red shirt to help you through that. And then when you decide what EMR is going to look like or what telemedicine is going to look like in your organization, it shouldn't just be administrators who make that decision. Common sense tells you clinicians need to be there, nurses need to be part of that process. So it needs to be pretty democratic in the way you implement it. And then form committees, specialty committees, like we have an OB-GYN committee that deals with OB-GYN issues and can take their concerns to the next step up. And then we talked about co-ops as well. So, keep getting stuck from time to time. Okay. So let's go to regulatory and financial barriers. So regulatory wise, confidentiality and breaching of safety is a big concern. Doctors also fear legal issues if, some of the data gets leaked. So, and if there's breach of confidentiality, I don't know how much of this is an issue here for you in India, but in the US, it's a big deal for us. And then there is this large, upfront investment. And we don't, there's no clear guidance as to which EMR to use and how to go about doing it. And what is a cost-effective EMR? What should we be looking for? So there is lack of guidance in that area. So how do we counter these financial and regulatory barriers? So there are industry standards now coming out that tell us what digital security should be looking like. And there are, in the US at least, there are mandated channels of digital channels you can use that are considered secure. You have to understand that, yes, there is, on one hand, you're paying the expense of digital security, of setting up telemedicine, but in the other hand, in the long run, there is a savings in your real estate, in your supplies, and your decreased wait times, and you will also improve patient satisfaction. And then you have to highlight to your organization all those things we talked about, the improving access, quality care, specialty care. It is an investment up front, but then you're able to capture a lot more visits to people who would have not otherwise been able to come to your clinic. And that's how you improve the market share of the organization, by providing comprehensive care. So I want to stop a little bit and talk about clinician burnout here. So I think we became familiar with this even more during COVID. I'm not sure how big of an issue this was in India personally, but there's plenty of research and data that points out to it, towards it here as well. So if you look at the symptoms, basically physician exhaustion, physical exhaustion, emotional exhaustion, people are just not happy with their work, and they feel some degree of depersonalization, which means they don't connect to their patients as well. They feel like they don't care about what they do anymore. Nobody cares. I think a lot of us went through that in COVID. We didn't recognize it so much before. But then this overall affects the well-being of physicians. And when physicians are burnt out, they don't do such a good job taking care of their patients. So eventually, it not only affects clinician well-being, but also affects the quality of care we provide for our patients. In the US, large number of physicians have left practice. There is a huge shortage of physicians. My friends who have left behind in the US, before we used to be able to see patients maximum. I know you guys do a wonderful job. You're able to see patients on the same day. I don't know how you do it. But we usually had a wait time of 3-4 days, or maybe a week we could see a patient. Now the wait time to see an OB-GYN is for 2 months, 3 months. And by the time that patient comes to see you, they're so angry that they've had to wait for 2 months that you basically feel like you need a shield to just kind of get through the visit. Physician burnout can be, changes from increasing administrative tasks, meaning now you have to learn EMR. In addition of taking care of 20-25 patients and patients being angry with you, and it's not satisfying to take care of your patients anymore, you also have to do billing. You have to make sure you close your charts. You have to make sure you document this, you document that. And then these technology shifts create a lot of changes in workflow and adaptations rather. And many of our older doctors, I remember my mother had a cardiologist. He was 80 years old when telemedicine got rolled out. He still wanted to see patients, but he would sit there till 8 o'clock at night trying to finish and close his charts. And eventually he just gave up and he quit. And he was such an excellent clinician. He trained me when I was in medical college. But by the time it got to the point, I think if it wasn't for EMR, he could have practiced for another 5 years easily. I think COVID-19 also created a lot of disruptions to what is normal for us, right? Both personally and professionally. So let's look at physician burnout in India. What does that look like? So there were 482 medical practitioners surveyed across India. This is a study from 2016, meaning this is a study before COVID. So even before COVID, when they looked at burnout, 45% had emotional exhaustion, 66% had high depersonalization scores, and 87% felt like they were not achieving enough. And the scores overall for like overload and lack of development, they were pretty high as well. So what are the solutions to this, to burnout? And telemedicine is part of the solution, which is why I'm talking about this on this lecture. You have to incorporate clinical leadership into larger digital strategies and decision making, meaning doctors, providers, nurses, mid-level providers, they all need to have a seat on the table. And when you design, pilot, and test out these applications and processes and workflows, they continue to give their input. And it's not just when you first set things up. As you keep moving along and making changes, you need to have a multidisciplinary team sitting and helping and guiding with what we call, M&E and quality control as well. And organizations that can provide seamless integration of patient and clinician interfaces, people who really focus on user interface, will have a competitive advantage compared to the rest of their colleagues. So I'll stop at this point. We're kind of at a halfway point. Are we doing okay on time, Dr. Umashankar? Everybody okay?
I think Dr. Umashankar is moving around, so I'm not sure if he has good signal, but
okay.
We are okay on time, doctor, right
okay.
now.
Anybody has any questions so far, or should I keep going?
So there are a couple of questions in the chat.
Okay. Let me see.
So one question is about regulations and challenges between inter-country telemedicine in OBG.
Right. So that is an area we have not addressed as because different countries have different capabilities. I agree with you that there is even a higher need of this happening. Walls are coming down. The world is becoming a much smaller place. And there definitely needs to be a conversation. But as of now, this is something that is not fully developed yet.
So just to follow up on that, is WHO or some other similar organization working on something like this to facilitate teleconsults across countries?
So I think COVID threw us off, big time, right? There are so many competing priorities with COVID that conversation just got derailed. But I think different and like telemedicine communities even within countries are somewhat new.
Right.
So it is going to be up to these telemedicine communities within countries, the leadership of these communities to come in and start this conversation. But as of now, this is a big gap. And it's a very good point that you bring up.
And so there is another question around setting up telemedicine in rural areas, especially for OBG, given that there are so many women who do not even get access to delivery at a government health facility or institutional deliveries rather.
Right.
So can we do something about that?
So from what I understand, the government is just setting up 1 lakh clinics in low resource rural areas where they are setting up a physical building. They are setting up digital infrastructure and they are setting up a trained low level provider like a nurse or an ASHA worker who knows enough in terms of how to collect basic information, chief complaint, vital signs. And then they are setting up a network of providers across the country, and the promise is when this is done that the patient comes and within 15 minutes there will be a provider available from this network of providers that the government pays. So the beauty of this system when it is fully functional is that if you don't want to go live in some rural village 2 hours from where your children go to school, you can still be helpful. You don't have to work full time in a village. You can do 4 hours, a week of your regular practice, and you can do 1 to 2 days of this. But this is still something that is in the works, that is a long way from the finish line. But I think, India is a model. If you look at other low resource countries and even high resource countries, this whole ASHA worker PHC model, is an exemplary example of what India has set up. Now, those of us who have worked at these PHCs, we understand that the physical infrastructure is there, but the quality human resource infrastructure is still a far ways away. But I think in a short period of time, we have made a lot of progress. If you look at the maternal mortality rate 20, 30 years ago, where it was, over 300 per 100,000, and now it is under 100 per 100,000. That's a sharp change in trajectory. So right. I think to some degree we have to be patient, and we are moving in the right direction, but obviously there's many a slip between the cup and the lip.
Sure. Yeah, maybe we can continue with your presentation, Doctor, and we can come back to the questions towards the end once again.
Okay. All right. So now we're switching gears to talking about telemedicine in OB-GYN specifically. And so telemedicine was first described in 1979. We mentioned earlier when a fetal monitoring strip was faxed from the hospital to the clinic for the patient to look at. That's a very basic, rudimentary definition of telemedicine. And since then, it has evolved and grown, as we all know. There's low risk obstetrics, high risk obstetrics. It is, I was chief of family planning for the city. It was huge for family planning. I don't think this lecture leaves us enough time about all the different things that we were able to do in family planning to make it work really efficiently. And then, of course, there's gynecology as well. So, what does the evidence show for telemedicine? What works? What doesn't? If you look at that, is it an adjunct? Or can it be an alternative to standard care? What is the evidence? So if you look at overall evidence for telemedicine, I think it works more for maintenance of health rather than initiation of health. There are some areas where it does help for initiation, for things like initiation of family planning or abortion care, for instance. And especially where we come from in the US, half the states now don't provide comprehensive abortion care. So a patient is able to call across state lines and get care and get help and get medication sent to them. So it works in certain areas, but it does not work for everything. So the data shows that it works for, it does not help for initiation of, like, let's say, smoking cessation in pregnancy, but it does help for maintenance. So once you've already met with the person in face to face, and you formed a connection, excuse me, then you can sit down and follow up with that person on telemedicine. And the same thing goes for contraception compliance. You came into the office, we started you on birth control pills, we went over a chart in person, you got to touch different birth control options, you got to get a feel for it, and or we put in your IUD, and now, you know, it's time for your 2-month checkup. That follow-up care telemedicine is very good at least this is what the evidence shows. Same thing goes for OB. It does not replace, obviously, obstetrical care, and neither should it, but it does decrease the need for multiple outpatient visits. You can decrease your number of visits. So moving on to policies, procedures, and protocols in OB-GYN. So, or in, I guess for that matter, for any specialty in telemedicine, there are some basic things that you need to keep in mind. You need to decide when your consulting hours are. Do you like doing telemedicine at the beginning of the day, at the end of the day? If you are, you know, going to the hospital for rounds in the morning and your mornings are very unpredictable, telemedicine is not a good thing to do at 8 o'clock in the morning, because once you start running behind, then it kind of compounds itself and adds incremental work to every subsequent visit. So set it at a time where you know you're going to be on time. Some people like doing telemedicine in between multiple face-to-face in-person visits because they feel like telemedicine gives them a break. Some people find the, you know, change in workflow from in-person to telemedicine too disruptive. And I was one of those people. So I like to bunch my telemedicine visits at the beginning of my afternoon shift, right after lunch break. When I know I'm in the clinic, I can start on time, and it gives my staff extra time to catch up on all the other work they need to do before starting our afternoon shift. So sort of also understand what inclusion and exclusion criteria you want. And we'll go over some of these things a little bit down the road on this presentation. And then also decide what you're going to do for urgent needs. Like, you know, somebody is having heavy vaginal bleeding. Obviously, that is not an appropriate person to see on telemedicine. Or what if you want to provide the yearly physical? That is also not something that you can do on telemedicine. So have these boundaries of what you are going to see and what you're not going to see, and have a policy around that. In terms of procedures, there are different roles and responsibilities for every team member. For us, we had a medical assistant who is not a nurse, a provider that is, you know, has lesser responsibility in education below a nurse, who checked the patient in, who asked them, have you taken your blood pressure today? What was your last weight? What medications are you taking? And then, you know, the nurse talked to the patient next and got some more medical history. Then the physician came on, and then the nurse checked them out. So what is the role and responsibility of every single team member that you have in clinic? Also, you need to look at consent. What should a consent have? How do you want to do your consent? Do you want to do it as soon as they log in? Is this something you want to send to them ahead of time and they sign it 1 or 2 days before? What sort of things do you want to document on a telemedicine visit? You know, that now in India, legal issues and medical legal issues are catching up just like they are everywhere else in the developed country. So if you don't document it, it didn't happen. So in terms of telemedicine, what are the important things to document, and how do you want to do that? What should your workflow be, and how should you bill? I find all of these things, if they are written out on a particular protocol as an SOP, and it's standard of care, that way, as your staff changes, as you have attrition, as you have new team members coming out, everybody's on the same page. Everybody reads the SOP, understands what their role is, understands what the responsibility is, and signs off on that. And clinical algorithms, and I'm going to get into that in a little bit in terms of exactly what that is. So let's look at who is eligible for a telemedicine visit. Patient has to be clinically stable. So I'm just going to throw some of these diagnoses out there. So if somebody has had a major, you know, vehicular accident, is that a good person for telemedicine? If they are in severe pain, doctor, I am in 10 out of 10 pain, I am dying, is that a good person? If they are having heavy vaginal bleeding, I have used 20 pads today, whether that is an OB patient or a GYN patient. When they have an acute fever, high fever of 103, 104, if they have shortness of breath, if they are acutely dizzy, I was fine, and then all of a sudden, over the next few hours in the morning, I just got really, really dizzy. If there is psychological instability, I want to kill myself. Should any of these patients be seen for telemedicine? The answer is a big, huge no. So that is what I mean by have your policies and procedure in place, that there are certain things the nurse should not say, oh, by the way, I thought you could see this person on telemedicine, so I scheduled them for a video visit. Everybody should know these list of diagnoses, whatever your specialty is, this is not a telemedicine visit. So let's go over broad categories of visits for OB-GYN specifically. So if you are initiating care and counseling, let's say somebody wants to talk about family planning and we're thinking of, having a pregnancy in a few months, what should we do? They don't want to drive all the way out to see the doctor if they don't know who the doctor is, the first time meeting them. And so they want to kind of get to know you, you're getting to know them. You're just basically going over basic history. Do you have sickle cell in your family? Any birth defects in your family? You want to basically order basic labs. Let's make sure you're immune to rubella. Let's check make sure you don't have thalassemia in the family, and that you are not a carrier. So that basic early conversation where you're not fully initiating care, but you're doing the very early steps of initiation and basic counseling, that's a good category of visits to have on telemedicine. If they are monitoring conditions, if you have an HIV positive patient, but who's overall stable and they're, you want to make sure they're compliant with their ART. If you have a high risk patient with diabetes and this is, they're only 10 weeks and they're well controlled, that's a person you can do intermittent visits on telemedicine. If this is a second opinion, like for instance, our infectious disease consult for Pune, that's a good telemedicine category. If you've seen the patient, they came in for dysfunctional uterine bleeding, you think they have PCOS, but you haven't had a chance to go over their labs and go over the second steps of evaluation, then that's something that you should consider doing on telemedicine. And minor surgical follow-ups, incision checks and so on. So like I did my first post-op check on telemedicine. But a caveat here is I would tell my patients, listen, if you have a fever, if your incision doesn't look good, if you are in severe pain, please cancel your video visit and come to the office. That is not something you should be doing on a video visit. That means I need to see you. I need to put my stethoscope on your belly and I need to figure out what is going on with you. If your incision has a seroma, whatever it is, I need to put my hands on your incision and figure out. So if everything is going well and we're just checking in, that's a good telemedicine visit. The next thing we're going to cover here is the telehealth consent. So this is, I thought, a good guidance by the Center for Connected Health Policy in the US. Informed consent is used to explain what telehealth is, lay out the expected benefits and the possible risks associated with it to the patient, explain to them what their security measures are, and it often requires a written form that needs to be signed by the patient or at least an oral acknowledgement that is documented in the patient's medical record. So this is a sample of a telehealth consent. It's a busy slide, but just to go over something really quickly, it describes what telemedicine is, that it is voluntary, that it does not cover emergencies, and that healthcare is confidential. And it gives them, what to do if there's a technology failure, and they are printing this. If they have a portal, they can print this and or sign it and upload it. So this is an example of a consent. I think it's a good idea to, have a consent for, it's up to you whether you want to do it for every visit or whether you want to have a consent every 6 months for people who do telemedicine pretty regularly. And then have them acknowledge it and have that to cover. So if tomorrow something was to go wrong, then at least they were an equal party in the decision making. So we're going to go through some clinical examples of what we see in OB-GYN. We talked over some basic things here, but somebody who says, I hadn't had any kind of vaginal issues for the last 4-5 years, and all of a sudden I have vaginal discharge for the last 2 days, uncomplicated, non-recurrent vaginal discharge. If somebody says, I've had irregular bleeding, irregular cycles for the last 5 years, and again, it is your first visit to gather history. I have a rash. We talked about low risk obstetrical visits and basically conditions where patients are stable, but maybe harmful to others. For example, if somebody has active chickenpox and they're pregnant, if you run an OB practice, you know, chickenpox in a patient who's sitting in your waiting area is a big nightmare. They're going to spread it to all the other patients, and their other patients can have birth defects. So then that's something you want to control. If you're basically doing genetic counseling, meaning we ran your thalassemia test or your cystic fibrosis test, and this is what it showed. We're going to move next to algorithms, because I think this is a big part of running a smooth telemedicine practice. So you have to sit down and think through, okay, if I see a gyn patient with irregular bleeding, what do I want to do with this patient when they first call? What kind of information do I want to gather? How can I make this more efficient? And we'll go through a few examples. So again, I'm repeating, but I think this is important. Who needs to come into the office and who needs to schedule a telemedicine appointment? Have that as the first part of your algorithm. Can they do any tests? Is there any information you can gather about them ahead of time, so they can finish doing some of these tests before they come to the office? So when they come to the office, especially if you are like us and you have to wait 3 months to get in, you don't want to wait another 3 months for them to follow up. So what can they do ahead of time so you have a productive visit the first time they see you? And what emergency precautions do they need? Does the patient need? And what is the staff, a new nurse that has graduated and now part of your practice, what sort of protocols do you need to build into place? So let's go over some of these algorithms. So examples of things you can build algorithms for in obstetrics and in gynecology. In obstetrics, you can have an algorithm for what to do when a patient has a first trimester bleeding, what to do when patient has second trimester bleeding or third trimester bleeding. What is your algorithm, for nausea, vomiting for pregnancy? Any OB-GYN knows that approximately 40 to 60% of their patients will call them with complaints of nausea and vomiting. How do you want to handle this kind of patient in your clinic? What do you do for preeclampsia or diabetes? When you look at gynecology, my bread and butter was abnormal uterine bleeding. I loved taking care of hormonal disorders, and so I got a lot of abnormal uterine bleeding. Vaginal discharge, every OB-GYN sees at least 10% of their population with vaginal discharge, pelvic pain, UTI. So there is a long list. What are the most common diagnoses you see in your office? You should have a basic framework of how you want to deal with it. So we've talked a lot about abnormal uterine bleeding. I'm going to go over an algorithm here for abnormal uterine bleeding. So the framework we use as gynecologists is called Palm-Cohen, which is basically, these are the top things of top diagnoses that lead to abnormal uterine bleeding: polyps, adenomyosis, fibroids, cancer, coagulopathy, endometrial dysfunction, endometrial pathology, and then iatrogenic. So this is a stepwise way of collecting data to help you make decisions. So the first question you ask is, how old were you when you started your menstrual cycle? And you document that. Do your cycles come at regular intervals? Yes, no, and what is the range? If the answer is no, your nurse should know to order a TSH, prolactin, and a CBC. And this is something the patient can do ahead of time. Third question, how long do your periods last? If it is longer than 7 days, again, you should be checking a blood count and a thyroid. Are they heavy? And there is if the answer is yes, and so on and so forth, the list goes on. Do you have any signs of anemia? Yes or no? And if the patient says she's dizzy, has chest pain or shortness of breath, first of all, that patient needs to be seen immediately. Second of all, that patient needs a stat hemoglobin and a pregnancy test. Because, does she have a ruptured ectopic? Is she just chronically anemic and has gotten this way? This is an emergency. So this part of the algorithm needs to be highlighted in a big red circle. Are you currently using any family planning methods? And if not, and if they want to not get pregnant anytime soon, your nurse can counsel them on birth control counseling. The point is, if you set up a framework ahead of time, you don't need to be sitting and thinking about these patients. Your staff can be trained. A well-trained nurse can help you minimize your work and minimize your thought process and decrease the chaos you have in your clinic. So my recommendation is for at least your top 10 diagnoses, have these sort of algorithms where you've thought things through, have different branch points in your algorithm and what to do at each branch point. And then you can structure your progress note according to your algorithm. So this is an example of what my progress note looked like on electronic medical records. We had Epic in India. In the US. So this is a template. So a template is something you create that you can sort of use on every patient who comes in with the same diagnosis. And the things that you see here that are surrounded by this @ sign, those can be auto-populated from your patient's medical record. So if you open Radha Patel's chart, Radha Patel's name will come up here. If in the chart it says she's 26 years old, 26 will pop in automatically. Her G's and P's will pop in automatically. These things that you see in brackets here, so these are drop-down menus. Periods heavy. If I press this, I have the option of yes or no. So I can keep click, going down the whole chart, and I am done in 3 minutes. And it is the same thing I use for every person who comes in with abnormal uterine bleeding. And I can add things to it depending on what I need. But I have covered every single question that I should be asking for abnormal uterine bleeding. I also have the complete history here in front of me. And I can document their physical exam according to what I need for abnormal uterine bleeding. Do they have any acanthosis nigricans? That's what this is. Do they have any hirsute hair growth on their face, on their breasts, on their abdomen? If we are doing this on telemedicine, obviously we can't see their breast and abdomen, but we can write down per patient's verbal report. This is what she's saying, yes or no. It's good to document things well. You should have a different template for telemedicine. You should have a different template for inpatient. I know it seems like a lot of work, but once you do this work and you set things up, it goes so quickly, so easily. I think the medical record that I've come closest to this in India is, I think, called Akhil, where you have the option of putting in medical history, surgical history, medications, and all of these things ahead of time. And some of this information gets auto-populated. I'm sure there are lots of medical records that do this. So going over workflow for telemedicine, some of this, again, here is repetitive, where make sure you have a checklist for your workflow for every different types of telemedicine visit. Designate your hours. When do you want to see this patient, these kind of patients for telemedicine? What is the client's responsibility going to be? They are going to have to sign their consent. Are there any other questionnaires you can send to them ahead of time that they can sign and turn in before the visit that helps you in your decision making? Can they check their audio and video visit before they come in, so that at the time of your visit, when you have 5 patients lined up, you're not wasting time trying to sort those things out? The medical assistant puts in whatever their information is. The physician reviews some of this thing that has been done. Ultimately, it is a physician's responsibility to make sure everything has been done correctly. They confirm with the patient, you are such and such, please tell us your date of birth. You get the main meat and potatoes of your visit. Why are you here? What is the main problem? How long has it been going on? What are the qualifying factors about your problem? You do a limited visual examination. You put in your orders and you sign your visit and you end it there. And then the checkout nurse tells the patient where they should get their ultrasound done and how to get their labs drawn and when do they need to follow up, and gives them whatever patient education they need, and they close out the visit. So this should be a basic fundamental workflow for every telehealth visit, regardless of what the patient is there for. This is a generic template on a larger perspective of what we need to get done with every telemedicine visit. Also, there should be some attention to telehealth etiquette, like what should your surroundings be? We've all had children, for those of us who have young children, we've all had young children pop into the screen, in the middle of a patient visit when we were at home in the middle of COVID. When we got COVID, when we were isolated, it didn't mean you could take time off. You still had to do telemedicine visit from your bed. So those are obviously not very appropriate or professional. But even if you're sick, we had such a shortage of doctors that everybody pitched in and did what they could. Unless you were dying, you were at least doing telemedicine. But what should your surrounding be in an ideal situation? So you need to have a place, preferably with a closed door where people are not coming in and out. It has where the patient's privacy is protected, where the patient feels like you're paying attention to them and not what is going on around you. And have a natural background. It's kind of disconcerting for a patient to have a virtual background. Is my doctor sitting on the beach somewhere? Like, why is the background blurred? It's just more professional to have a natural background, I feel. Turn off other devices and notifications, meaning don't have your phone ringing while you're trying to do a telemedicine visit. Dress professionally, have your name clearly. People like me who have difficult names to pronounce, the patient sometimes loses track of things. So have your name clearly visible. And then test your own equipment before you take off. And then put your webcam and your monitor close to each other as much as possible. You don't want to be seeing the patient here and typing over here. You want to be able to make eye contact while you're typing. If I don't type while I'm speaking to the patient, I will forget half the things later. So I usually type as I'm talking to the patient, but I either put my screen in such a way where I can maintain eye contact and type at the same time. So then you also sort of inform patients that confidential questions may be asked. So during the clinic visit, you tell them, listen, in OB-GYN, we ask a lot of confidential questions. How old were you when you were first sexually active? Are you using birth control? Does it hurt during intercourse? All these questions are not something somebody wants to answer in front of their mother-in-law or in front of their cousin. So you tell them ahead of time that, listen, I may be asking you certain confidential questions. Can you make sure that you're in a place where you have privacy and you can answer these questions freely? Make sure at the beginning of the visit you introduce. So I always start the visit with this. I'm such and such. You are such and such. Can I confirm your name and your date of birth? All right. Then the next thing I tell them is, I'm going to be asking you certain confidential questions during this visit, just so that we can get to know you better and we can do a good job helping you. If the more we know about you, the better we can help you. Can you make sure you're in a place that, we can answer and talk to each other in full confidentiality? And then you start the clinical visit very similar to your in-person visit. You build some rapport, especially if it's not a first-time patient of yours. You make sure that there is a good connection between the two of you. Can you hear me okay? Can you see me okay? And then at the end of the visit, you make sure, did I answer all your questions? You want the patient to be satisfied with the telemedicine visit so that the patient comes back and makes your life easier the next time as well. You let them know that they will need to stay online for their checkout process, if you have one. So, just let them know the nurse will be with you shortly. She'll tell you how to make your follow-up appointment and what to do next. Organizationally, it's a good idea to have quality control. So this quality control chart is for billing that we do in the United States. Who was the clinician? What was their ID? What date, what visit type, was the consent signed? Is the billing appropriate? The same way, you can also have certain quality control measures in your organization for providers, for your nurses. Did they do all the things they were supposed to do? Did they make the follow-up appointment? Did they counsel the patient? Did they send, if you told them to send information on birth control pills, was that sent to the patient's email or their WhatsApp message or whatever little method you use? It's always a good idea to make sure you have quality control, especially if you're a larger organization, because many times if you are sitting on top, you don't know what is happening at the grassroots level, and then your whole system sort of crumbles and falls apart. So you have to make sure quality control is a part of this. Future of telemedicine, there are a lot of new things coming. Everybody's talking about AI. Everybody in the dog is talking about AI and how to bring AI-aided dictation systems. How will AI take over and read X-rays and CT scans? How will AI listen to the patient's conversation and tell you what the diagnosis is, what the treatment is? Some of those things are already here. Some of these things are still a work in progress. You have to be cognizant of biases with data, especially when you use AI. If you put garbage in, you are going to get garbage out. So for instance, there is AI in pathology for pap smears. If the AI technology does not have a good database of normal pap smears, abnormal pap smears, different types of abnormal pap smears, if it does not have a good database that is fed into it, it is going to feed out inaccurate results. So make sure that whenever you're adapting AI, that you have sort of looked into how did they develop their AI? What was their method to come up with their AI? Does it sound? Do they have enough data to build AI? And then when you're looking at expansion of services, whether it is remote monitoring, tele-ICU, telestroke, telehealth in ED, make sure you have all the building blocks in place and you have algorithms and SOPs and all of those things that we talked about. Apps and platforms. The next slide, I just was in the morning reading my emails, and I get this email about this new wearable device that you've come up with that I'll show you a picture on the next slide. It can tell you what your bowel sounds are doing. It can tell you what your breathing is like, when somebody stopped breathing. So these are all up and coming. There are drones now for drug deliveries and military transport. In Africa, when I worked, sometimes we would hear of drones bringing in, blood for blood transfusions. Small villages many times didn't have any blood products for transfusions, and then they would get delivered by drones from the cities. There's robotics, of course. For those of you who are robotic surgeons like I am, you know how much fun it can be. But robotics is not just in surgery, it's in prosthetics. It is in somebody who can be a home companion for somebody who's elderly, somebody who can help with physiotherapy, somebody who can help with skilled nursing in step-down units. And then there are all these hearables as well, not just wearables, but hearables, where there are things that, your watch will tell you about your pulse being too high. So how does a user interface with some of the data that is being collected through wearables? So this is the email article I got this morning in my email saying, this broadband acoustic mechanical system. So how I was telling you can't listen to somebody's bowel sounds on a telemedicine visit. Well, this supposedly, you put it on their abdomen and it will transmit their bowel sounds to you. And you can listen to their chest as they keep moving it around. You can listen to their heart and heart sounds as they keep moving it in different places. So basically, this can be used as an apnea monitor in the NICU, apnea monitor for sleep apnea patients in the adults. It is going, if it takes off, and this is very new, but this will change telemedicine and how much we can do with telemedicine safely. I'm just putting some resources here in terms of, I've shared this presentation with Dr. Uma Shankar, so I'm sure he can pass them on to you. But if you want to take a quick picture of articles, telehealth interventions to improve obstetrics and gynecology, and then these are different resources here put by the US Health and Human Services. And the Cleveland Clinic has a digital health playbook as well. So if you want to take another quick picture, I'll hold on the slide for a little bit. But these are some of the resources I have to offer to you to help with telemedicine in general and telemedicine in OB-GYN specifically. So this was my practice in Houston before I left. In medicine and in life, we start out being dependent. We are dependent on our parents when we are born. We are dependent on our teachers and our mentors when we start practicing medicine. Then with some experience, we start becoming independent and we learn how to handle things on our own and we get more confident. But then we often forget the next phase of this growing up process, which is interdependence. So this was the team of people I worked with for 20 years. Some of them joined down, like maybe I worked with some of these people for 12, 14 years, but we were a solid team. We really liked each other. We really got along well. If one of us learned a trick in telemedicine, we emailed everybody, we texted it to everybody. Hey, I found this. You can do this on electronic medical records. And I have made a template. You can all, feel free to use it. I think it's important when we try to do something new in medicine that we do it as a community and we don't work in silos. So I just wanted to sort of bring this, there is all this technology out there, but there's also a community in telemedicine that is important, which you guys are doing really well by having this whole society of telemedicine practice and so on and so forth. But even on a smaller scale, look to the friend that you call if you don't know how to answer somebody, and set up a little co-op among telemedicine practitioners in your communities. I think it's really, really important, and it can, save you a lot of frustration and pain. So I'll stop sharing my screen, and so I can see your faces, and see if you guys have any other questions at this point.
Thank you, Doctor. There are a couple of questions which I think you have partly answered as well.
Okay.
So things like newer trends in software and technologies and telemedicine in OBG, and what's the role of AI-based applications and wearable devices?
Right. So, in OB-GYN, so AI, we touched on a little bit. There is AI coming in terms of writing your notes. There is AI, like if you have a speaker that is in the office or and you're either talking to a patient on telemedicine as well as, or in person, the AI will write a note out for you and spit it out. But I don't think it is at the point where you can just, not even look at the note, not make any corrections, not proofread it. It still needs some work, and it's, of course, not very easily accessible right now, which is a dream come true for me. Can you believe that, you can sit there, make eye contact with the patient, you're not typing anything, you're like, oh, you're talking like a normal person, like you used to talk to patients, before all these computers took over. And it's such a nice feeling to go back to that. And there is AI coming up there. Then there is, of course, AI coming up where you put, certain data. If you input, these are her vital signs, it goes through an algorithm where it spit out a diagnosis at you. There's AI in radiology. There's AI in treatment algorithms. And then there is AI in diagnostics and telemedicine as well, like we talked about, the little device you can, that can listen to your heart and listen to your lungs. So multiple fronts where AI is coming up. And then there are some things that I probably haven't even touched or not even aware of. This is, you wake up tomorrow morning and there's something new in AI. What was the other question? Software technologies.
Right. So wearable devices, you all also answered, and
So
software and technologies in telemedicine, especially in OBG.
Right. So, electronic fetal monitoring is a reality now in telemedicine, where your high-risk patient, they need their weekly fetal monitoring. And, if they know where to find their baby, they can do that. They don't need to come into the office and sit in there for 2 hours. We had patients monitor their the blood glucoses, through their continuous glucose monitors, their CGMs, and we would get a weekly report. We have patients upload their blood pressure charts, and we have interfaces with their blood pressure machines where they will send us data every time the patient takes a blood pressure. I think we have to be careful. Sometimes it is information overload. I think one of the things that the system has failed providers is that none of our other workload has gone down. Instead, now we have all these other inputs coming in. Now we have to answer 15 emails. In addition, we have, we have to look at people's blood glucose monitoring charts, once, twice a week. We have to look at their blood pressure charts. We have to sort of do all these different things. So I think there needs to be a wake-up call in terms of our administration and our organizations looking at our workflows and making it more feasible. Otherwise, you're going to lose more doctors. So that's sort of a broad overview in terms of technology coming up.
Sure. And again, you briefly mentioned about the kind of devices, fetal monitors and blood glucose monitors, which could be used. Are there any other devices specifically for OBG, for low resource settings especially?
Right. So I think there is basic ultrasounds now that have come up with that, can be done with your phone. There are a lot of interface differences, whether it's video visit, whether it's a computer-based, just an audio visit, so on and so forth. There is electronic prescription sending where we send our prescriptions directly to the pharmacy. So there is no error between, the pharmacist could read your prescription, and also there is medical error reduction in electronic medical records. If you have a good program, if there's drug interaction, most programs will flag and say, this patient is over 80, don't give them high doses of quinolones, or this person has a heart condition, maybe you should not be prescribing such and such medication. So there's a lot of reduction in medical errors that has come up with because of telemedicine as well. So as technology grows, as it becomes more intelligent, hopefully our life will get easier. But I don't think most of us feel that our life has gotten easier quite yet.
Sure. So there are no further questions on the chat. If I would open it to the forum. If anybody has any other questions, please you may ask now.
Madam, can I ask a question?
Sure.
Yeah, I am from Cuttack, Orissa, from SCV Medical College.
I see.
And hospital.
Welcome.
Okay, I belong to Department of Plastic Surgery, in fact.
Okay.
But the problem is, mostly in ICU, when you have admission of pregnant patients, and in those cases, you require ICU care with burn patients with pregnancy. Usually, central ICU don't entertain that because of infection to other patients. So in that situation, how telemedicine can help these patients, and not only that, especially when there is acute renal failures, and where we can do a peritoneal dialysis at periphery centers, not medical college, periphery centers. So how the applications of telemedicine can be helpful for these pregnant patients? And as for the peritoneal dialysis, what will be the time store where it can be safely given to the patients? Because this is a national program by the government of India, as far as peritoneal dialysis is concerned.
So I don't think I'm qualified to answer many questions about dialysis because I don't understand the technical limitations you have here in India. But in terms of obstetrical care, I can definitely answer those questions. So now I have a patient in the ICU. Let's say she came in with COVID and she happens to be pregnant, right? So that baby needs to be monitored. If she's in the late second or early third trimester, the baby needs to be monitored. Now, we are trying to limit how many patients are going in and how many people are going into that room, how many people are coming out of that room, right?
Yeah.
So now there is one nurse, the nurse puts on the monitor, the monitoring is relayed here, at my desk. I'm in my office. I'm not even in the ICU. So I've looked at the baby looks okay. I do a video visit with the patient. How are you feeling? Are you feeling okay? I've logged into the chart. I've looked at all her parameters. What are her vital signs? How much oxygen is she requiring? What is her fever curve? What is she looking like? So if she's not on the ventilator and she can talk, everything I need to make sure this patient is stable from an obstetrical standpoint, I don't ever have to walk into the room to do that. Everything is possible on a video visit or telemedicine or through electronic transmission. And the internist has gone and listened to her lungs and made sure she's okay. So I don't need to go behind the internist and listen to the lungs a fourth time. The intensivist has taken care of all of that. So, and we were able to conserve a lot of resources like this in telemedicine. Many times when we had COVID positive patients, and you guys did that too, before going into the room, you would call them. So are you doing okay? What is going on? All the subjective part of your SOAP note. SOAP note is subjective, objective, assessment, and plan. Everything subjective you needed to do, you didn't even step into the room. You called them ahead of time. You got the information. If they had access to a video device, WhatsApp video, whatever, you did that. You eyeballed them. You go in, for 2 minutes, examine them, make sure that they don't have a DVT, that their lungs are, doing what they're supposed to be doing. All the data is all on the computer. Everything is accessible to you. So OB care did get very easy for us during COVID because there was one nurse, one monitor, and we as obstetricians, we were tied up with our own COVID pregnant patients who were in active labor and stuff. We didn't have to go and check on normal pregnant, people who just happened to be pregnant but didn't have any pregnancy comorbidities at that time. So
Thank you, ma'am. Yeah, I think you have answered almost all important part of it. And it's a great job, in fact, telemedicine doing for all these critical patients.
Right.
Thank you, ma'am.
I think there still needs to be a lot of support and infrastructure to make it better, but the possibilities are very exciting.
But the only problem, in government setups, you have a change in 8 hours. The nurses changes and the doctors are also changing. That is one of the problem in government setups. Maybe private, maybe little different. So that is
that's
the only
where
problem.
telemedicine, the thing is, there's a big upfront cost. But can you imagine this, that where there is a good electronic medical record and shifts keep changing, and somebody has input the data correctly, and the AI spits out and gives you a summary where you don't, patients, especially when they are sick and they are not feeling well, they are not the best historians. So if somebody can summarize all of that information and give that to you in half a page, then your life is made much easier. You can practice much more efficiently.
Yeah, madam, that is a nice suggestion. Good, very good. Thank you, ma'am.
You're very welcome.
Thank you.
So, doctor, you also talked about cost. There is also a question here. What is the average cost per patient there in the USA initially and after practicing over the years, as far as your specialty is concerned?
So it's short-term pain and long-term gain. This holds true for telemedicine and EMR big time. It depends there, I cannot give you an average cost because it depends on what telemedicine is so varied. If you get an EMR like Epic, the cost is really high. But depending on, you can pick and choose, you can cherry pick which parts of Epic you want. So in our co-op, we were all doing only for OB-GYN. We did not want an ICU, protocol in Epic. So we picked and chose what we wanted. So cost is going to depend on the size of your organization, on the scope of your electronic medical records and what applications you need to have, and what existing infrastructure do you already have. Do you already have laptops and computers in your office, or are you going to have to buy them new? Do you already have webcams and things like that, or how much are you going to need to update? How much are you going to need to buy? So it's a very variable answer depending on your pre-existing setup, the size of your organization, the scope of your telemedicine electronic medical record that you are trying to do. Once you set that up, and in US it was mandated, when Obama signed his healthcare electronic medical records, by a certain time, if you have a certain type of practice, you are obligated to have electronic medical records, or you have to pay a penalty. A lot of people didn't like that in the beginning because, there was a big upfront cost. Then these cooperatives helped us, where we came up and we negotiated and were able to bargain with these electronic medical providers as a large group. Like, it's not just me in my office. I have 15 other people who will sign on to your electronic, and the larger the group, the more bargaining power you can have.
Right.
So there are a lot of variables in that ask. I've seen really cheap telemedicine here in India where everything is done on WhatsApp. Everybody already has a WhatsApp, application on their phone. Not everybody, but most people, a lot of people do. And so then it becomes very easy to have that conversation. I think in rural areas, I'll give you an example. I went to this village in Mysore where we were doing HPV-based cervical screening, and one of these poor ladies was positive. And we're trying to call her, please come to the clinic, and nobody can get a hold of her. Finally, we went to the village and her phone is switched off. And we're like, why is your phone switched off? She's like, I don't have enough money to recharge my phone. What do you have do you have a husband? He's dead. Do you have children? Yeah, I have 2 daughters. They're both married and they're both in their house. Do you have any sons? Yes, my son is disabled. So I can barely eat enough. And so how am I going to recharge my phone? And so we finally said, okay, you need to come to clinic. We need to do a colposcopy. And she's like, who's going to take care of my child? So yes, telemedicine can make your life easy in some ways, but it doesn't have all the answers. Ultimately, we paid her some money to recharge her phone and said, we'll send our hospital van to pick you up. So there are things it can do and there are things it cannot.
Sure. Yeah. Are there any other questions from anybody? No, I guess. So thank you so much, doctor.
Thank you.
This was a very good session, and we have exceeded the time limit, and people are
so
still.
Sorry.
No, but I think people are still around, so it's been a good session, and there is a lot of interest in the subject of telemedicine and specifically in OBG. So this was very useful. Thank you so much. And
Very
I would
good evening to all
also,
of you.
And I would like to also thank all the participants for taking time out to join the session. And I hope it was useful for everyone. Any closing remarks, Dr. Umashankar?
It was an excellent session, Dr. Devanshi. I think you brought out essence of telemedicine as well as especially in practicing in OBG. Not many people are practicing telemedicine in OBG. Hopefully from now onwards, they should start. And I was just thinking we should start some master classes or workshop how to practice telemedicine in OBG, because people do not know about that, how to practice. Other systems they can do, but in OBG it's very difficult. Not many people are even making an attempt. I was speaking to some of the gynecologists. They say it's very difficult. How do we do it? So I think we should do it for all the OBGYN practitioners in India, a session so that they can improve their practice in telemedicine.
You know, if you're an organization, I think you have the power to create these collaboratives between people who practice similar ways of medicine. So you can have a repository of these are, you know, workflows for nephrology. These are workflows for OB-GYN. These are workflows for people who are doing pulmonary. And these are note templates you can use. And then people can take and, you know, tweak it a little bit and personalize it to what their liking is. But you know, this is a wonderful place for you to have a repository where you can make this more efficient for people and not as painful and not as intimidating a process.
Yeah. I would take this platform to request you to help TSI in you know, formulating this and guide how we can take it forward, especially gynecology and telemedicine.
Yeah, no, I'm happy to.
Thank you.
You know where to find me.
Thank you so much. Wonderful. Wonderful.
All right. Thank you for giving me the opportunity.
Thank you so much. Good night. Bye-bye.
Good night.